Hi everyone, and thanks for tuning in to this virtual presentation of our accepted abstract. We have no relevant disclosures or conflicts of interest. C. difficile colitis is one of the most common hospital-acquired infections, and is typically preceded by antibiotic exposure. In rare instances, the disease can progress to fulminant C. difficile colitis, characterized by end organ damage and a toxic colon. In such cases, surgery is typically indicated, and for many years this came in the form of a total abdominal colectomy. However, colectomy for fulminant disease was still associated with poor outcomes. Mortality rates from single-center studies range from 30 to 80%, postoperative morbidity after emergency laparotomy was considerable, and very few patients underwent takedown of their end ileostomy. In 2011, Neal and colleagues from the University of Pittsburgh described an alternative operation for fulminant C. diff colitis, introducing a minimally invasive colon-preserving option that would still eradicate the toxin-mediated mucosal illness. The operation included 3 steps: a diverting loop ileostomy, most commonly performed laparoscopically, intraoperative antegrade colonic lavage with warmed polyethylene glycol, and postoperative antegrade colonic enemas with vancomycin for 10 days. Their original report, published in 2011, demonstrated remarkable benefits to this new approach. Compared to historical controls who underwent colectomy, patients who underwent loop ileostomy experienced a 75% risk reduction in postoperative mortality, and all but 3 patients retained their colon. Since then, very few studies have evaluated loop ileostomy in this clinical context. A recently published systematic review, including 5 studies, reported equivalent mortality, morbidity, and reoperation between the 2 procedures, but with very limited data on rates of GI restoration. The largest study on this subject was an NIS paper published this past year, which reported an increasing use of loop ileostomy for C. diff over the study years, from 11% in 2011 to 25% in 2015, and equivalent mortality, but given the inherent limitations of the database, all outcomes were limited to the index admission. Therefore, the purpose of this study was to compare outcomes beyond the index admission between patients who underwent loop ileostomy or colectomy for fulminant C. diff colitis. We queried the nationwide readmission database, which, like NIS, is part of a family of databases developed for the Healthcare Cost and Utilization Project. It is a nationally representative database containing greater than 17 million discharges per year, and is unique in that admissions from the same patients can be linked within the same calendar year and within the same state, which makes it a particularly suitable data source for studying readmissions and post-discharge outcomes. We included all adult patients who underwent loop ileostomy or total abdominal colectomy with a primary discharge diagnosis of C. diff colitis. Patients with a secondary discharge diagnosis of C. diff colitis were also included, so long as they did not have a concurrent colorectal procedure code or diagnostic code. This method ensured that cases of loop ileostomy or colectomy performed for other diagnoses and where C. diff infection represented a benign postoperative complication rather than the indication for surgery were excluded. 3 post-discharge outcomes were assessed: overall mortality, which we defined as the index admission mortality plus any in-hospital mortality occurring on readmission within 90 days of discharge, 90-day unplanned hospital readmission, and 6-month GI restoration, which was defined using procedural codes for loop ileostomy closure and end ileostomy takedown, respectively. Given that patient admissions can only be linked within the same calendar year, a washout period was required to ensure that all patients had an equal opportunity to develop the outcome of interest. For 90-day outcomes, only patients discharged from their index admission between January and September of each calendar year were included, to ensure that all patients had a 90-day follow-up. And similarly, for 6-month outcomes, only patients discharged between January and June were included. Patient and disease characteristics were compared between patients who underwent loop ileostomy versus colectomy, and multiple logistic regression models were generated for all 3 outcomes, adjusted for the covariates listed here. In total, 2,070 patients were included for analysis. Just over 70% of patients underwent colectomy, compared to 28% who underwent loop ileostomy. And patients who were otherwise eligible for inclusion, but who were excluded solely because of their discharge date, were no different than those who were included. Patients who underwent loop ileostomy were fairly similar to those who underwent colectomy. Loop ileostomy patients were more likely to have private insurance, but had a similar median age and gender distribution. Loop ileostomy patients also had lower proportions of extreme or class 4 APR-DRG risk of mortality and severity of illness. But overall, both groups were fairly sick and representative of patients with fulminant C. diff colitis, with roughly 3/4 having extreme illness and risk of death, septic shock, and renal failure. Of the 2,070 included patients, 70% were discharged alive, giving an index admission mortality rate of 30%. Crude index admission mortality was lower among patients who underwent loop ileostomy, 26% compared to 32%. Among the 1,434 patients who were discharged alive, 25% had an unplanned 90-day readmission, and this was similar between both groups. On readmission, another 33 patients died, which was 2.3% of those discharged alive. 90-day post-discharge mortality was similar between both groups. And when combined with index admission mortality, the overall mortality was still lower among loop ileostomy patients, 28% compared to 35%. When the cohort was further truncated to include only those patients discharged alive from January to June of each calendar year, only 13.6% of patients underwent a GI restoration procedure within 6 months, and this proportion was significantly greater among patients who underwent loop ileostomy, 26% compared to 8%. And on multiple logistic regression, compared to total colectomy, loop ileostomy was no longer associated with lower mortality. Loop ileostomy was also associated with an equivalent 90-day unplanned readmission, but loop ileostomy was associated with greater odds of 6-month GI restoration, with an odds ratio of 2.68. This study has a number of important limitations, mostly related to the database. We were missing important preoperative clinical and laboratory data, which could have resulted in residual confounding between the two groups despite multivariate regression. We were also forced to restrict our cohorts by calendar month in order to properly link patients and provide a similar follow-up in all patients. However, we did demonstrate that included and excluded patients were similar on patient and disease characteristics. And finally, we were unable to reliably detect C. difficile recurrence, which is important to record in the colon-preserving group, especially after loop ileostomy closure. So in conclusion, in the surgical management of fulminant C. diff colitis, loop ileostomy is a valid alternative to colectomy in appropriately selected patients and is associated with greater rates of GI restoration. Thanks for listening.